Good afternoon, everyone. On behalf of the young men who have sex with men and the PrEP provision sub-study study team, it is my pleasure to share with you the result of the study. This study is a collaboration between the Ministry of Public Health and the Centers for Disease Control and Prevention, or the CDC. The study conducted at 3 study sites. The first site was at Siloam Community Clinic. This site is operated by the CDC. The other 2 sites were Bangkok Hospital located in Bangkok and the Rainbow Clinic in Nakhon Sawan Province. These 2 sites were operated by the Department of Disease Control. This young MSM study enrolled young MSM and transgender women aged 15 to 29 years into the study. From the figure, we had 254 participants screened, and the overall HIV prevalence was about 5%, which is comparable to the COPE estimate. Transgender women was about at 2 times higher of the HIV prevalence when compared to the MSM. Participants who had HIV negative were enrolled into the cohort study that provide HIV and STI services, with the follow-up visit every 3 months for a total of 12 months. Participants enrolled at the Siloam Community Clinic were offered PrEP services. During the study period from 2017 to 2019, PrEP service was not available at the other 2 study sites, which is the Bangkok Hospital in Bangkok and Rainbow Clinic in Nakhon Sawan Province. As you can see that the HIV incidence at the Siloam Community Clinic was 0 because this site is offer PrEP service. And the site that not offering PrEP in the service, the HIV incidence was around 7 per 100% years. However, the retention at 6 months were different across the study site, ranging from 90% at the Siloam Community Clinic to 60% at the Bangkok Hospital and only 22% at the Rainbow Clinic in Nakhon Sawan. So the HIV incidence at the site with low retention may be underestimated. These figures show the prevalence and incidence of Neisseria gonorrhea infection, or the NG, of 226 participants enrolled into the cohort. 216 participants provide urethral and rectal cell-collected specimens. We define NG as the positive by PCR test. The results show that the overall NG prevalence, regardless of anatomical site and regardless of symptom, was about 10%, with the confidence interval ranks from 6 to 14%. The overall NG incidence rate was 16 per 100% years, with the CI around 10 to 30 per 100% years. The rate by site ranks from 10 at Siloam Community Clinic to 15 in Rainbow Clinic in Nakhon Sawan Province and 28 at Bangkok Hospital. The NG incidence rate among 3 study sites was not significant difference. Our results show that the gonorrhea rate between the sites with or without PrEP service were similar. So offering PrEP in the service does not increase the NG incidence. These figures show the prevalence and incidence of chlamydia trachomatis infection, or CT. We define CT as the positive by PCR test. The results show that the overall CT prevalence, with regardless of anatomical site and regardless of symptom, was about 18%, with the confidence interval ranks from 12 to 23%. The overall CT incidence rate was 37 per 100 years, with the CI around 25 to 54 per 100 years. The rate by site ranks from 20 to around 40 per 100 years. The CT incidence rate among 3 study sites was not significant difference. This figure shows the result of PrEP sub-study. We had 53 HIV negative participants aged 15 to 24 years enrolled and eligible for PrEP. Of 53, 30 participants started PrEP. The PrEP uptake was about 55%. We found that among participants who started PrEP, 90% had ever tested for HIV infection before joining the study. But among participants who did not start PrEP, only 66% reported the history of HIV testing. This finding was statistically significant difference with the p-value less than 0.05. From our result, we can summarize that the HIV prevalence was about 5% and the prevalence was about 2 times higher in transgender women. The site offering PrEP had 0 HIV incidence, and the site without PrEP had the rate around 7 per 100 years. We found the substantial prevalence and incidence of CT and NG infections detected by PCR tests, regardless of symptom and also regardless of the PrEP service. Interest in PrEP was high, including the age under 18 years old. Lastly, the incident report in this study made subject to underestimate because there was a heterogeneity of study retention between the study sites, which ranged from 20% to 90%. And these are the list of our sponsors and collaborators. And thank you for your attention. We are happy to answer if any questions.
Much for presentation. I think the speaker showed us that the population that they work with and enroll in the research project is very high risk, high prevalence rate of HIV and also STD. But they have a very good programs that have very high retention in the programs, high uptake of PrEP. So I think this is, we have time for about 5 to 10 minutes about discussion about if you have experience providing PrEP or have questions for Thailand US CDC team, why they have so excellent in terms of retention and adherence that we can exchange our ideas and techniques in order to use in our clinical practice. So before I start, how many of you in the room providing PrEP? You are a PrEP provider or ever providing PrEP?
Not many, nah.
So we wait a little bit, the hand is going up. Yeah, we have providing PrEP, but I think we can share our experience, our obstacles, our challenges. So after we finish this session, we have more confidence and more encouraged or empowered to providing PrEP to the client.
Actually, before we listen to others, I think this is a very, very good program, which is remarkably better than other programs. We experienced that usually young people, they have very good retention, but they're not very good adherence. So we experienced that in several programs, including the ones in us, when you ask them how many pills they take, oh, excellent. And they always come back, because they love our counselor, they love our program. But then when you check the blood levels, then you know the truth. That less than half of whatever they report that they taken the meds, actually less than half they really taken it. Okay, so I like to hear. Okay.
Please, can I just ask, was there any financial incentive for the participants in your study? I mean, were you paying them to come to clinic?
Yes, of course. Yeah,
It's
because
structural
Yeah.
structural to overcome barriers.
actually we call that like a travel incentive. Like just to pay for their traveling or how they get to the clinic and how they spend the time with us. Because remember that the target population is the young MSM and TGW who had experienced history of selling sex. So the time is money. Yeah, so at first we offer at MOPHEC for ethic for MOPHEC for lower compensation, but they say that because this group is very special and it's very hard for us to hold them in all the study procedures, which can take around 2 or 3 hours long. So time is money for them, so they ask us to increase the incentive, and that worked because they say that it worth to come to us to stay in our study. So of course we have that, and we have the quarterly visit for one rate. But if they have prep, let's start prep with us. So we have the prep pickup visit too. So they come to pick up prep each month. So we have different rate for the compensation. So if they spend time with us, they get that compensation. Yes.
Please.
Yeah, Wan Thi from CC Cambodia, and thanks very much for sharing the, best program, more than 90%. So can you have some kind of 3 best practice or lesson learned from your program? One, from healthcare provider, what are the best things that you want to share with us? Secondly, in terms of community, to what extent that you involve community with your program to ensure that the adherence is very high, whatever. And the third point is, what are the things you address with the client or with the people who involved in your program? So those 3 things we just want to learn from you.
Yes, for the COPE study, let's start with COPE, okay? So COPE study, we have the 4 study settings and all from the community clinic. So we set the time, like an operation time after work. We start around 3 in the afternoon until 10 p.m. So it works for people who after work, so they can come to the clinic. And for the community, we have the community people who know the culture, know how to talk in the MSM or TGW language. They know slang, they know how to communicate. So it's not like a simple, regular, general counseling message to this group. So we have the special how to bond and relationship between the counselors, which are community people, and the participants that we don't call them sex workers, because you can see that we call them the MSM and TGW who had a history of having sex exchange with a man. It's long, but it works because we don't name them sex worker, and that touched their heart. Mm-hmm. Yeah, and they know that we don't stigmatize them. And it's like it's a counseling. We have the prep counseling technique, and we have trained all the counselors, and we provide all everything that like the counselors or nurses who know how to talk to them. The one who's not the MSM or who's not TGW learn how to. We have a culture learning about this group. And what else about that? The compensation, of course, and one-on-one counseling is an individual focus for the counseling technique for each of them, and the location. For swing or ASAT or Silom Community Clinic can access through BTS, and it's not on the boat, the public boat, so it's not that hard to access, and after work it works for them. Because this group, they kind of get up late, around like maybe 1 or 2 p.m. So it's very hard to find them in the morning. So we try to change everything for them. And for the counselor or nurses, we don't have the uniform, don't have like a like medical form that make them like so scared. So they're dressed like MSM, dressed like TGW. So that worked, and we blend in. I think that's the message. Yeah.
So those are the tricks to work with the young people. I'd like to hear a few words from Steve on the prevention program you work.
I can talk a little bit about PrEP in Cambodia. Hi, I'm Steve Wignall, and I work with the EPIC project, FHI 360. Cambodia has enrolled about 6,000 in PrEP, but retention is about half that right now. But there are some unique examples in government-based clinics that have a CBO model, largely personality-driven, where accessibility is extraordinarily easy. There are very strong linkages with the community, and there's one health center that has enrolled about 40% of all of the PrEP cases in Phnom Penh. The largest group of key populations in Cambodia is in Phnom Penh, and I don't think that we have to say that CBOs can always do it best. What we need are people that are highly motivated, connected to the community, and are willing to make their services accessible to young people. We have now 20 PrEP sites across the country in Cambodia. 17 of those are in government facilities, and 3 are CBO sites, but a significant percentage in the last quarter. The CBO PrEP delivery started in the last 2 quarters, and 40% of new PrEP enrollments have been in CBO PrEP sites. So indeed, having community members recruit community members, I think is extraordinarily important. And I think one thing that I haven't heard in the discussions here today is that we've talked a lot about case detection and finding positives and putting positive on treatment. But nobody has said about the negatives, how much, what percentage of those people that we're testing that are negative and high risk are we enrolling in PrEP? And we have to have both of those targets if we're going to win this battle in Asia, particularly with MSM-driven, women-driven epidemics, I think. But we don't seem to link those two things. We talk about PrEP separately, we talk about testing and treatment separately, but they really absolutely need to be linked. And if they're not on treatment and they're at risk, then we need to be doing everything we can as clinicians or as community representatives to encourage those people at risk to be on PrEP. Thank you.
Oh, very good example.
Yeah. Dr.
Nat.
Natalie?
Good afternoon. Hello, is this working? Hello, can you hear me? Yeah, okay. So my name is Nat. I'm a pediatric infectious diseases fellow at Chulalongkorn University. I have a question about the last slide you showed on the incidence of transgender women. I thought it was very interesting that the rate was double that of MSM. So at our center at Chulalongkorn, we look after about 15 to 24-year-olds, and about 10 of them are transgender women. And our experience is keeping them in follow-up is much more challenging than MSM. So I wanted to ask you about what your experience was with retaining, because you have excellent retention figures, and also, do you think there's anything in particular in the cohort you looked after to explain the figures that were double in transgender women? Thank you.
Unfortunately, we, in our sample size and the follow-up period, which is asylum, is from 6 months to 1 year, we don't have much of the transgender women that we can estimate for the incident rate. And for our experience from the previous study, before this study, we found that the transgender, they don't come back to the MSM clinic. Yep.
Okay, thank you very much. Because interest of time, we would like to thank the speakers that share their experience about PrEP. And if you have any questions or comments, you can talk to the speakers directly. We will have a short 10-minute breaks for like go to restroom and also have coffee outside. And when we come back at maybe 5 minutes to 3, we will have interesting session, the clinical cases that you can vote, you can share your experience and get some tips and tricks from the speakers to bring back to your clinics, to taking care of STD, to taking care of advanced HIV disease, and also HIV and hepatitis C co-infection. So please enjoy your break and come back in next 10 minutes. Thank you.